Hello and welcome to today's review. Today we are going to look at Jan 2014 paper 1. We have our question 1. Reduced tactile fremitus may indicate. We have accumulation of mucus in the respiratory tracts, atelectasis, pneumothorax, pulmonary edema, pericardial effusion and pleurisy, hemothorax and pleural effusion. Right, so here we are looking at something that can be able to block or impede transmission of vibrations from the upper part of the respiratory system to the lower and to the body holistically. So we're supposed to look at what is able to reduce it, right? To reduce those vibration, right? All right, so if you look at option number 1, accumulation of waste in the respiratory tract. Actually, accumulation, this one normally causes increase and not a decrease, right? It will cause an increase, while atelectasis will decrease as you have, as it is required in the option. But the first part may not work for us. Option 2, pneumothorax. Of course, pneumothorax, atelectasis, all of them are going to decrease. But this pulmonary edema is not related to the fremitus, right? The conduction of the vibrations. Peripheral effusion, pleurisy, if you look at them again, not related to this condition. The best option for us or conditions that are going to reduce tactile fremitus or may indicate, this may indicate maybe someone is having hemothorax or pleural effusion. As we have indicated, when the density of the lung tissue decreases, it will impede the transmission of vibration. So these conditions are the ones that will be implicated here, right? Pneumothorax and peripheral effusion. So hemo, this is blood in the pleura. Pleural, that is effusion, that is fluid in the pleura. So all of them are going to impede the vibration, making it the best answer. In the management of salicylate poisoning, the casualty may be given. All right, activated charcoal, intravenous vitamin K. Activated charcoal can help by binding by binding the loose or the available salicylate in the GIT. But I don't see how intravenous vitamin K can help reverse this. So this one will not be included here, unless if you're talking about a coagulation disorders where we lack the vitamin K factors. That's when we can use it. But for now, no. Option B, intravenous glucose and dexaferizine. For the intravenous glucose, maybe if you are talking of hypoglycemic event, that can work. And also for deferoxamine, this one maybe when you're talking about iron poisoning, that's when you may need this one. So this option is completely wrong. It does not answer our question, which is asking about, we are trying to reverse salicylate poisoning. Option C, we are talking of IV sodium bicarbonate and water enema. When you take IV sodium bicarbonate, this one will normally alkalize urine. And when you alkalize urine, you increase the elimination of salicylic acid. So this at least answers the question. And what about enema? Enema is going to lead to rapid excretion. That is, it will in doing so, it is going to reduce the absorption of this substance. So that can also reverse the poisoning effects of the salicylate disease, and this makes the a correct answer for consideration. Vitamin B complex and potassium sulfate, this one they don't answer our question at all. They don't answer our question at all, and it makes it wrong for us. So the best option for this question is C. Priority nursing diagnosis for a child with intersusception is intersusception. Now we're talking of acute pain related to bowel obstruction and surgery. We are having a fluid volume imbalance less than body requirements related to vomiting and sweating. Ineffective tissue perfusion related to bowel obstruction and diarrhea. Parental anxiety related to child hospitalization and surgery. I think this one is more of psychosocial, so it may just try to rule out this one, so that we remain with option A, B, C, and ineffective tissue perfusion related to bowel. Yeah, this is still circulation. Fluid imbalance leading to this is circulation and fluid and electrolyte imbalance, and then we have pain here. All right, according to Dr. ABC, circulation I think takes precedence over the rest, so we can rule out that option A. So we remain with fluid volume imbalance less than body requirements related to vomiting and sweating, and infective tissue perfusion. So how can we correct this infective tissue perfusion? Probably through surgery. So you see, surgery may take time. I think for us as nurses, we could work with what is more possible for us, and I think this one also, in addition to that, has the greatest impact, in that when you try and work on vomiting and sweating, this can try and restore or correct electrolyte imbalance. Also, the fluid, again, you work on it, which is going also to affect the circulation. So if you address this one, you'll be solving at least one of the main problem for this patient. So B is the best answer for us here. Pharmacological management of Myasthenia gravis, right? Myasthenia gravis, neurological disorders here, and looking at the options that you have, dopamine, attain. I'm sure all of us know that dopamine we normally use to treat Parkinson's disease, and attain we normally use to manage the extrapyramidal side effects, especially the tremors, right? Potassium chloride, if you're correcting potassium imbalance. Capidopa, also treatment of the disease that we have just mentioned. Nck-Bscn, this is you remember what is the cause of Myasthenia gravis? We have under-stimulation of cholinergic neurotransmitters, right? Cholinergic neurotransmitters. So when you give Nck-Bscn, which is an agonist that can help. And prednisolone is a corticosteroid. It's an anti-inflammatory drug, so that will also help, because the problem normally comes as a result of inflammation of those neurons. So this could be a good answer for consideration. Attain, we have already talked about extrapyramidal side effects, right? Although Nck-Bscn and neo, they belong to the same class. This one makes it not appropriate. So C is the best option for us there. Number 5, you're being asked the difference between pulmonary edema and acute severe asthma presentation. Is that the former? All right, so the former is the first. Right, so which is the first condition? Pulmonary edema. Right. So, pulmonary edema. Pulmonary edema tends to present with severe central cyanosis and crepitations of the lungs. Number 1 says no respiratory So this condition normally presents with respiratory signs. So this makes this one wrong, especially which conditions? Dyspnea, cough, wheezing, right? It causes tachycardia, fever. The rub is not there. The rubs makes those options wrong. That's why we have settled at option C. The acquired predisposing factors for kidney calculi include the kidney stones, right? And it has to be acquired, not genetic. High sodium excretion, familial hypercalciuria. Familial hypercalciuria can cause, but it is genetic, it's not acquired. High sodium excretion. When you have high sodium excretion or elimination, it also follows with calcium. So actually this one will reduce, right? It do not predispose someone to stones. Hypercalcemia and ileal section. Again, ileal section makes this option to be wrong. Cystinuria and high oxalate excretion, they have to accumulate to cause those stones, right? Renal tubule acidosis and low urine volumes predisposes one to kidney stones. The principle of autonomy in nursing means autonomy, avoiding causing harm to others. This is non-maleficence, right? Yes, non-maleficence. Keeping promises made to patients or relatives. It's a principle of fidelity, right? Giving the patient his or her due by acting fairly. That's justice, right? Yeah, justice. So it goes without saying, option D should be the correct answer. But you can just confirm, respecting patients, rights of patients and relatives to make their own decision. Yeah, that one you have at least upholded the principle of autonomy, right? Autonomy. When you decide to them, that's when we talk of paternalism, right? But this is autonomy. The physician prescribes morphine for a 3-year-old child who has sustained severe injuries. You will not hesitate to administering the drug if the dose is. So what is the correct dose for morphine? Should not be too low. Like this one is extremely low, right? Extremely low, or just low, right? Or too high. This is elevated, right? Best one is 0.1 milligrams per kg per body weight. The predisposing factors of retinal detachment. Retinal types of retinal detachment we are here now. And the best option here is option A. Myopia and tumors of the eyeball will predispose one to such disorders, right? Hypertension, yes, it can also predispose, but not all refractive errors, right? Like refractive errors like hyperopia does not. So it makes this option to be wrong. Degenerative changes in the retina, yes, but papilloma it doesn't cause. High myopia and sudden exertion. The exertion is not widely recognized as a risk factor for retinal detachment. As regards management of pain in pediatric palliative care, right? Yeah, I'm afraid the first one is correct. Meperidine, this is pethidine, right? It should be avoided as it can cause central nervous system irritability, right? Irritability. The maximum dose of codeine is 600. Remember, codeine is not recommended in peds. Degenerative opioid analgesic should be avoided as they cause respiratory depression. Yeah, it's true, but we normally use. So maybe best thing to say here is that we have to encourage judicial use of, right, of opiates. First step may be controlled by Valium. This is wrong, right? Valium or diazepam is not the first line of treatment. The difference between threatened abortion and inevitable abortion is that the latter, we just say the former is the first, the latter is the second, right? So here we are comparing threatened abortion and inevitable abortion, right? Inevitable abortion. Looking at this, so we're talking, there is bleeding and lower abdominal pain, but cervix remains closed. Threatened, inevitable, this may not be. There is associated rupture of membranes without passage. Yeah, inevitable. Membranes are ruptured without the passage of the tissues, right? Without the passage of the tissues. That is the best option there. Going on to number next, the factor mostly associated with development of Alzheimer's disease. Alzheimer's disease is associated with amyloid plaques, right? The amyloid plaques deposited in the brain, and option C is what closer to what we were talking about. Peptide of 39, 49 amino acid deposits in the brain will lead to Alzheimer's disease. To facilitate venous filling during venipuncture, one should position the limb to be punctured to the same level of the heart. By so doing, it will facilitate venous filling by allowing gravity to assist in the flow of blood to that area, right? And that will be of help to that patient. The first steps in the process of removal of skin sutures. All right, removal of skin sutures. Of course, we have to ensure that we don't injure the skin, right? We don't injure the skin. So the best option here, we have not don't injure the skin and remove the sutures, right? Option C appears to be the best here, using the dissecting forceps to grasp the suture and then inserting the tip of the scissors underneath to cut it. Remember when you say using the dissecting forceps to grasp, this will stabilize the suture, then inserting it to cut underneath is that it will allow not to damage the skin, right? The tissue, the body tissues. The time to occlude the suction catheter vent when suctioning the tracheostomy is, you occlude because you want to create some negative pressure, right? You want to create negative pressure that will allow effective suction, So the best time or moment to do it is before inserting the catheter into the tracheostomy. So you create the negative pressure before you proceed. The dietary causes of iron deficiency anemia, dietary, right? Dietary. Bleeding, this is going to bleed blood loss, so it's not a dietary after all. Exclusive breastfeeding beyond the 6 months. I'm afraid this is maybe one of the best answers to be kept for consideration. Impaired gastrointestinal absorption and resection of the small intestines. These one are going to reduce the absorption surfaces for iron, and that may not be directly linked to dietary, right? So breastfeeding is the main culprit there. The clinical manifestation of hypokalemia on the gastrointestinal system. Hypokalemia will lead to distension, right? Decreased bowel sounds, nausea, thirst, and pancreatic ileus. In short, we have an inactive GIT, right? Inactive GIT. So looking at this one, I'm afraid for these ones they didn't have an outright answer, as C and D tend to be the correct options, right? Because hypokalemia can cause distension, it can cause decreased bowel sounds, and all this is because of the inactive GIT. Nausea because there is obstruction of the flow of the food contents. So someone may feel nauseated, thirsty, and could suffer from pancreatic ileus, and that makes any of these to be correct. The risk factors for ineffective carditis include infective carditis. I think the best option here, because here the problem is the gender is not a direct cause or a risk factor. Pulmonary hypertension, not really, because catheterization, of course, it might introduce microbes. Mitral incompetence, yeah, but thrombolysis, rarely. And the best option here is the one that's mixing of the blood from the right to the left, and also intravenous drug use are the major risk factor for infective candidiasis. In fact, intravenous drug use is the most common factor or cause, the major cause of this one, because it introduces so many microbes into those tissues. The risk factors of cancer of the ovaries. Cancer of the ovaries. All right, obesity, yeah, I agree. But diabetes is not a major cause of a major risk factor for cancer, right? Major risk factor for cancer. So just to help me, I think I can use it to rule out some multiple choices so that I'm remaining with family history B and C, right? B and C. So family history of endometrial cancer, looking at the ovaries, yeah, this one will be more of associated with it than this one. Exposure to asbestos, infertility, yeah. Then prolonged estrogen use, yes, and family history of cancer of the breast, yeah. This one is at a greater risk of developing that disease compared to the others. The features that describe taper point atraumatic surgical needs. Atro, that means without traumatic. So without, that should just guide you to A, right? No cutting. Atraumatic. Without, right? Remember, when talking about one cutting edge, this one is normally seen in specialized needles, while the two cutting edge used for retinal repair, this one is normally used in delicate areas like the eye, as they have indicated. Triangular is normally found in cutting needles required for penetration of tough tissues, while no cutting one, this one normally penetrates tissues without cutting, right? Without cutting. So that is the best option for us there. Okay, what about the short answer questions then? We had state 4 manifestation that may suggest a child undergoing management for severe pneumonia has developed empyema. So in a child being treated for severe pneumonia, the development of empyema, of course, empyema, we are saying this is a collection of pus in the pleural cavity. It can be suspected through the following manifestation: when there is persistent or worsening fever, increased respiratory distress, chest pain, coughing with decreased lung expansion, dullness to percussion, reduced breath sounds, poor response to antibiotics, and patient presenting with systemic symptoms. Number 2, you are told to draw and label a diagram to illustrate a mature long bone, right? A mature long bone. So we need to have the epiphysis, which is this rounded edge of the bone, diaphysis, which is long cylindrical shaft of the bone, diaphysis, right? Then you have metaphysis, the region between dia and epi, often contains the growth plate in children and adolescents. Articular cartilage, periosteum, compact bone, spongy or cancellous bone. Then you have the medullary cavity, endosteum, and nutrient artery. Explain how hypercoagulability occurs in nephrotic syndrome. Remember, nephrotic syndrome is characterized by massive protein loss through the kidneys, leading to hypoalbuminemia, edema, hyperlipidemia, and aprothrombotic state. So generally we have the loss of antithrombotic proteins. So with this proteinuria, key anthropometric proteins such as the antithrombin 3, protein C, and protein S are lost in the urine. These proteins normally help regulate clot formation by inhibiting excessive coagulation. Their reduction normally leads to unchecked thrombin formation, prompting clotting. We also have another reason why there is hypercoagulability. We have increased levels of proagulant factors. So the liver will compensate for protein loss by increasing synthesis of several proteins, including the procoagulant factors like fibrinogen, factors 5, 7, 8, and 10. So elevated levels of these factors will enhance blood's tendency to clot. Increased platelet aggregation in nephrotic syndrome is associated with increased platelet activation and aggregation. This may be due to alteration in blood composition and increased levels of aggregate agents like thromboxane A2 promoting clot formation. Hypoalbuminemia also leads to increased blood viscosity, especially with increased fibrinogen levels. So this sluggish blood flow can contribute to venous stasis and create an environment conducive to clot formation. The endothelial lining of blood vessels may become dysfunctional in nephrotic syndrome due to inflammatory mediators and oxidative stress. This dysfunction can reduce natural anticoagulant activity, allowing for increased clotting. Nephrotic syndrome, lastly, is associated with elevated cholesterol and triglycerides. So high lipid levels, particularly lipoproteins, are known to have prothrombotic effects, contributing to the risk of clotting formation. Number four is talking about stating factors that may precipitate heart failure in patients with pre-existing heart condition. So we have conditions like, and maybe we need to know how they do it, so we have factors that can precipitate or worsen heart failure by either increasing the heart's workload or disrupting fluid balance or impairing cardiac functions. We have factors like the infections, hypertensions, arrhythmias, myocardial ischemias or infarction, non-adherence or diet, and fluid overload, Anemia, thyroid disorders, renal dysfunction, pulmonary embolism, physical or emotional stress, and substance abuse all can precipitate heart failure in patients with a pre-existing heart disease. Explain postoperative care for a 7-year-old child following tonsillectomy. So we have several interventions. We have air management, where you keep the child in semi-folus position or on their side to promote drainage of secretions and prevent aspiration. Then you monitor for signs of respiratory distress such as the stridor or labored breathing, which could indicate airway obstruction due to swelling. You also do check signs of hemorrhage, which is a common post-tonsillectomy complication. So you look for continuous swallowing, throat clearing, vomiting of blood, or bright red blood in saliva. You also need to monitor for heart rate, blood pressure, respiratory rate, tachycardia, hypotension, which can be signs of significant blood loss. You administer prescribed analgesics, usually as acetaminophen, ibuprofen, just to manage throat pain and reduce discomfort. You avoid aspirin due to its association with increased bleeding risk and potential for Reyes syndrome in children. You encourage the child to avoid coughing, throat clearing, and speaking unnecessarily, as these actions can increase pain and irritation. You hydrate the child, so you begin with small sips of cool, clear fluids like water or apple juice. And once the child is fully awake, once the child is fully awake, all right, then you avoid hot or acidic fluids, as this can irritate the throat. Then you can gradually introduce soft, non-irritating foods, e.g. mashed potatoes, gelatin, once tolerated. You avoid sharp, crunchy, or spicy foods that may cause trauma to the surgical area. You ensure adequate hydration, as you know dehydration is very common in post-tonsillectomy. And signs of dehydration could include dry lips, dark urine, and lethargy. You also do the oral hygiene by gently encouraging the child to rinse the mouth with cool water or antiseptics. Rinse to maintain oral hygiene without disturbing the surgical area. Monitor for fever, increased throat pain, or foul-smelling breath, which could indicate infection. You also need to reassure the child and family, explaining that discomfort and mild pain are normal but will improve over time. You provide quiet activities like coloring, reading to keep the child entertained and minimize active play, which can increase the risk of bleeding. You also need to teach the family about the signs of complications, right? E.g. bleeding, infections, and the importance of follow-up care. You also need to provide the discharge teaching. You advise limited activity for the first week to prevent strain on the throat. Then you advise continuation with soft, cool foods and adequate hydration, and avoid foods that might irritate the throat. Guide the caregivers on appropriate dosing of prescribed pain medications, emphasizing adherence to the prescribed schedule to prevent breakthrough pain, and educate caregivers to seek immediate medical care if the child experiences significant bleeding, difficult breathing, or signs of dehydration. The next question is, you are supposed to describe the management of a patient with status epilepticus. You have to do the initial assessment and stabilization. So you ensure the airway is open, administer oxygen, and provide ventilation support as necessary. Check and monitor vital signs including pulse, BP, respiratory rate. Then position the patient on their side. That's the recovery side, just to prevent aspiration and protect the airway. Establish intravenous access as soon as possible for medication administration and fluid management. Number 2 is about immediate anticonvulsant therapy. Remember, first line treatment, you administer a benzodiazepine to rapidly stop the seizure. Option could be IV lorazepam, 0.1 milligrams per kg up to 4 milligrams, repeated once if needed, or IV diazepam, the Valium, 0.15, 0.2 milligrams per kg up to 10 milligrams. May be repeated if needed, right? You can also use IM midazolam, 10 milligrams if IV access is unavailable, right? Benzodiazepines are generally effective within minutes, but a second dose can be given if the seizure persists. For the second line treatment, if the seizure persists, you can use the antiepileptic drugs. If benzodiazepine do not stop the seizure, you administer a long-lasting anti-epileptic agent to maintain seizure control. Common choices could include IV phenytoin 20 milligrams per kg administered slowly to avoid cardiac arrhythmias, IV phosphatoin, that is 20 milligrams. It is preferred for its low risk of infusion-related complication, okay? Phosphatoin over phenytoin. We can also use sodium valproate, that is between 20 to 40 milligrams per kg if phenytoin is contraindicated. And also IV levetiracetam, 20 to 60 milligrams per kg, especially useful in patients with drug interactions or other contraindication to phenytoin or sodium valproate. For the ongoing monitoring, you can do neurological monitoring, vital signs and cardiac monitoring, laboratory investigations. Third line treatment, this is refractory status epilepticus. If the seizures persist after first and second line treatment, you initiate continuous infusion of anesthetic agents such as IV midazolam infusion, IV propofol infusion, or IV pentobarbital infusion. These medications require intubations and ICU admission for close monitoring. You have to ensure that you have investigated and managed any underlying factor contributing to these seizures, such as the electrolyte imbalances, hypoglycemia, infections, muscle meningitis, head injury, alcohol or drug withdrawal, or non-compliance with the medications. Post-seizure care and monitoring, you continue to monitor for recurrence and manage any complications including respiratory depression or arrhythmias. And then you have to adjust and optimize maintenance anti-epileptic agents therapy. Then provide education and counseling to the patient and family to prevent future episodes. Number 7, you are requested to explain immunologic changes following burn injury, right? Burn injury, immunological changes. We all know that the skin normally acts as a primary barrier against pathogens, and when someone has a burn injury, it's going to compromise this barrier. This will allow pathogens to enter the body more easily, and this will increase the risk of infection and systemic inflammation. Burn injury also triggers a strong inflammatory response, releasing cytokines such as interleukin-1, interleukin-6, and tumor necrosis factor alpha. These cytokines can lead to systemic inflammation, which can progress to a hyper-inflammatory state known as systemic inflammatory response syndrome. Burn injuries also cause functional impairment of neutrophils, which are key cells in the innate immune system. Neutrophils may become less effective in killing pathogens, either due to reduced chemostasis or impaired phagocytosis, further increasing the infection risk. Burns can also lead to the complement system, activation of the complement system, which is just a series of proteins that promote inflammation and marking of pathogens for destruction. So excessive complement activation may contribute to tissue damage and inflammation, worsening burn injury and promoting pro-inflammatory states. We also have adaptive immune suppression, where T cell function, which is a component of an adaptive immunity, will be significantly suppressed following a burn injury, and there may be due to decreased production of the T helper cells, which reduces cellular immunity and weakens the overall immune response to pathogens. And due to the combined effects of skin barrier loss, systemic inflammation, and immune suppression, burn patients are at high risk of sepsis, so the body's diminished ability to contain pathogens, combined with excessive inflammatory responses, can lead to widespread infections and septic shock, which is a major cause of mortality in burn patients. So we have Mrs. R, aged 60 years old, has been admitted to the ward and she is for total hysterectomy due to multiple fibroids. After assessment of Mrs. R, you identify one of the nursing diagnoses, potential for thromboembolism related to the nature of surgery and age. So you're being requested to justify the nursing diagnosis and you state 6 preoperative evaluation aspect of Mrs. R and also describe the postoperative nursing management of Mrs. R. Of course, Mrs. R is at heightened risk for thromboembolism due to both her age, we are talking of 60 years, and the type of surgery, the total hysterectomy. Age is a risk factor for decreased vascular elasticity and blood flow, which can contribute to blood clot formation. Additionally, hysterectomy requires prolonged immobility during and after surgery, and this will increase the risk for venous stasis, which can further predispose her to thrombus formation. So together these factors justify the diagnosis for potential for thromboembolism, age, and the type of surgery. As for the preoperative evaluation aspect for Mrs. R, we need to review any history of clotting disorders, cardiovascular disease, and other comorbidities that could affect her surgery outcome. So you need to assess hemoglobin levels, coagulation profile, the PT, the NR, and the APTT, and blood typing in case of transfusion requirements. Then evaluate for varicose vein edema and signs of current thrombosis that may indicate risk for complication. Identify medication that may need discontinuations, such as anticoagulants or NSAIDs to reduce bleeding risk. Conduct an ECG and possible an echocardiogram, especially given her age, to rule out underlying heart conditions. You explain the procedure, potential complication, and post-operative expectations, including early mobilization to reduce thromboembolism risk. As for the post-operative nursing management, you do monitor her vital signs and assess pain and also rule out signs of thromboembolism. You also look at prevention of thromboembolism, so encouraging leg exercise and gradual ambulation, applying anti-embolic stockings or pneumatic compression devices to improve venous return, and then administering prophylactic anticoagulants as prescribed to reduce clotting risk. Lastly, we have pain and comfort management, so that you administer prescribed analgesics and non-pharmacological interventions, and you reposition frequently and maintain her in a comfortable semifolus position to promote better respiratory functions and circulation. Wound healing, you do wound care and hygiene and asepsis care. You also need to document fluid intake and outputs as you watch out for signs of dehydration or fluid overload. Gradually progress from clear foods to solid food and ensure a balanced diet with adequate protein to support wound healing. And then also do patient education and emotional support. That's post-surgical education and emotional support. Last question you're being asked, Miss Master Z, age 10 years, has been admitted to the ward with the diagnosis of type 1 diabetes. So you explain the pathophysiology of type 1, and then you set 5 symptoms that may suggest the child has diabetes. Then describe the immediate and long-term management of Master Z. Of course, type 1 diabetes is an autoimmune condition where the immune system mistakenly attacks and destroys insulin beta cells in the pancreas. This destruction leads to obsolete deficiency of insulin, and of course we know insulin is a hormone that is necessary for glucose uptake into cells for energy production. So without insulin, then glucose will accumulate in the bloodstream, resulting into hyperglycemia. So the body cells cannot access the glucose for energy, and this will lead to an increase in ketone production as the body metabolizes fats for energy. Then over time, we have now chronic hyperglycemia, which can lead to various complications affecting multiple body systems. Symptoms could be polyuria. This is increased urination, and this is normally due to excessive glucose in the blood causing osmotic diuresis. Increased thirst, that's polydipsia, as a result of dehydration caused by excessive urination. Increased hunger, polyphagia, because the cells are starved of glucose, so they start looking for alternative sources of energy. This could predispose the patient to DKA. Due to the breakdown of fat and muscle for energy, it could lead to also an intentional weight loss. And also due to the lack of glucose available for energy production, it could also lead to fatigue. So immediate management involves insulin therapy, where you administer short-acting insulin to stabilize blood sugars and prevent DKA. You monitor blood glucose levels to guide insulin dosing and assess glucose levels. And if DKA is present, you rehydrate and correct electrolyte imbalance, especially potassium levels. You educate on blood glucose monitoring, insulin administration, and cognition of hypo and hyperglycemic symptoms. Then you develop a meal plan with the appropriate carbohydrate intake to manage blood glucose effectively. For the long-term management, you have to come up with a tailored insulin regimen involving basal and bolus insulin to mimic the natural insulin patterns and that will help manage blood glucose over time. And we have now continuous blood glucose monitoring to allow for real-time glucose level monitoring and better glycemic control. We have routine medical follow-up, like checking and rule out complications like retinopathy, nephropathy, and neuropathy. Encourage a balanced diet with consistent carbohydrate intake and educate on carbohydrate counting, and then provide emotional and mental health support for Master Z with his family just to cope up with the lifelong management of this diabetes. Ladies and gentlemen, we have several topics that have been covered here in paper 1, and I think you can also review what we are trying to project so that you familiarize yourself with topic 1 questions. Paper